One of the doctors, Jim's intern, asked me how big the opening in Jim's back was. Big, I said. You could put your fist in it. And I wasn't exaggerating. She looked intensely curious. Do you want to go look? I offered, acting briefly as a tour guide to the view of Jim and his amazing split back. She did want to look, and a couple of the other interns came to look as well. These doctors, I was glad to see, marveled at Jim's back the same way I had. The intensivists didn't seem nearly as impressed, but while they were deciding what to do, someone noticed a large puddle of brownish fluid on the floor and asked, "Did that come out of his back?" When I said that it had, a moment of surprised quiet rippled through the room before the conversation continued. By this point, Penny was sounding almost apologetic. "Well, his respiratory status was already pretty compromised," she said, "and now it's gotten worse." Respiratory status, I wondered. This guy had an 8-inch opening in his back, a clean incision offering a view of living tissue in all its multi-layered glory. Get this guy to the OR, I wanted to scream. But it wasn't that simple. The patient had a seroma, a fluid-filled sac that can develop at the site of a previous surgery. Several months before, he had a mass removed from his back, and that removal must have led to the accumulation of enough fluid to split open his back, soak the sheet he was sitting on, and splash in a big puddle on the floor. When a large enough mass is removed from anywhere on the body, it leaves a cavity or space. That space will fill with fluid as part of the healing process, but too much fluid makes it impossible for the tissue to regranulate or regrow. To prevent that, surgeons often place drains in wounds to limit fluid collection. I don't know if Jim had a drain placed following the initial surgery, but regardless, the large cavity in his back accumulated more and more fluid over time, until the pressure became too great for his body to bear. Something had to give. The pressure from the seroma overcame what surgeons call the tensile strength of the skin incision, causing the patient's back to dramatically, if painlessly, rip apart. Moving him from the bed to the chair probably contributed to the bursting of the seroma. We would have pulled his arms forward to move him, stretching taut the already weakened skin on his back. What disturbed me, and what it took me a while to get over, was that his skin had been unbroken before it split. When the dust settled from the code, I called my husband and said, "My patient's back split open at work today." And he asked, "Just like an alien?" To which I answered, "Yeah, just like an alien, except without the alien hopping out at the end." I wasn't the only one disturbed either. For days afterward, Penny said, "Let's not have any back split open today, okay?" What happened to Jim would be unsurprising on a surgical floor, but for most of us, even people in healthcare, it violates our sense of the normal, takes us into the realm of horror movies or science fiction. The bizarre ripping noise, the sudden spread of fluid just dark enough to possibly be blood, the puddle of water next to the patient, and the gaping opening itself makes one look to see if Freddy Krueger of Nightmare on Elm Street is flexing his deadly fingernails, when in reality Jim's body did this to itself. A seroma results from the healing process going awry, and even then some seromas will drain back into the body on their own. Unfortunately for Jim, his did not. And where was Jim in all this? The patient may seem to have been forgotten in this story, but Jim showed no awareness of the activity swirling around him. His respiratory status had worsened, along with his degree of obliviousness. His daughter had been in the room with him all morning, but she had left to get some lunch before we came to move him. Off and on all morning I had heard the doctors speculating as to whether he needed to be transferred to the ICU. It isn't always clear which way someone will go. No one expected Jim's back to split open, but it was his respiratory status more than his back that got him moved to the unit. After the doctors stabilized his breathing, they would pack the wound and maybe use a wound vac, or vacuum-assisted closure, to try to get his back to heal from the bottom up. Stitching him back together in the OR would only lead to the formation of an abscess since the wound was no longer sterile. First things first, though, they needed to get him breathing okay. ABCs, we heard it over and over again in nursing school. Airway, breathing, and circulation. Is the patient's trachea open? Is the patient exchanging oxygen and carbon dioxide? Does the patient have a pulse? These are the central questions, and they should always be asked in that order. If the patient can't breathe, fixing the hole in his back will not help him survive.